Hello, everybody. Welcome to the PrecisCa Hematologic Malignancies Tumor Board. Very happy to have you here. Very excited to go through some of these really interesting cases. The cases that we are going to focus on today are all patients with various forms of lymphomas. We have an outstanding panel with us here today to go over these cases. I'm very excited to be amongst them. I'm going to first introduce myself. I'm Dan Pollier from the University of Colorado, and I'd like each of my colleagues to introduce themselves. Dr. Fromm, please.
Hi, my name is Tyler Fromm. I'm an assistant professor of radiology with appointments in abdominal imaging and nuclear medicine at the Washington University School of Medicine in St. Louis, Missouri. I specialize in oncologic imaging with a focus on MRI and PET examinations.
Larry Keston. I am a radiation oncologist in Michigan, in the Detroit area. I work for Michigan Healthcare Professionals and Genesis Care USA. I'm the medical director of the Michigan region.
Hi, I'm Jeremy Abramson. I am a medical oncologist specializing in lymphoma. I direct the lymphoma program at the Massachusetts General Hospital in Boston, and am associate professor of medicine at Harvard Medical School.
John Pagel. I am the chief of hematologic malignancies and the director of the stem cell and cellular therapy program at the Swedish Cancer Institute in Seattle, Washington.
So this is a 41-year-old woman with non-bulky stage 1E diffuse large B-cell lymphoma. She received 6 cycles of RCHOP. And now the question that we're going to be addressing is whether this patient should have consolidative radiotherapy. And then, some more specific questions as to whether it should be IMRT to spare some of the toxicity. So, Dr. Keston, we're going to be relying on you quite a bit here in a moment, but just to go through her case, she presented with left leg pain and swelling at the left knee, and it was originally thought to be lupus, and the patient ultimately had an MRI. Her performance status was 0. She has a history of skin cancer, hyperlipidemia, and a couple of procedures. She's a social drinker, non-smoker, and has an oncologic history in the family, but no hematologic malignancy history. So in July 2020, she was found to have this large femoral mass, which was biopsy-proven DLBCL with a Chi67 of 80%. She was staged as a 1E. She was BCL2 positive. Her c-MYC was not overexpressed, and she did have a gain of 1 copy of BCL6 and a gain of MYC and the BCL2. The PET-CT showed the hypermetabolic left distal femur lesion, and we'll take a look at that here next. So, Dr. Fromm, if you don't mind taking us through the pre-imaging MR scan here. Or I'm sorry, this is a PET scan.
Sure, yeah. So on the left side, we see the pre-treatment images. We have an axial fused PET-CT image and some coronal and sagittal reconstructions there, and we see a hypermetabolic lesion that is centered within the marrow space of the distal left femur. Seems to involve the metastasis as well as the femoral condyles. And there's also some extraosseous extension into the medial soft tissues. And we're also told that there were some other sites of disease located more cranially. We're not actually seeing those on these images, but there sounds like there were some nodal sites of involvement as well that this PET scan revealed.
Great.
Note, if there were nodal sites of involvement, this patient would not have stage 1 disease.
Yeah, they do list hypermetabolic iliac and aortic lymph nodes, so that's a good point. And they also performed a brain MRI. So Dr. Abramson, when you look at the genetic information here, what does this? How would you read this story and further categorize this patient's biology?
This patient has, and I missed, unless it's on a prior slide, did we get the germinal center markers on this? Do we know whether it's CD10 positive, BCL6 positive, MUM1 positive?
Yeah, I think we just know. I think just this bullet here with respect to the genetic information. So you would need more data to kind of really genomically classify this patient.
I would. DLBCLs that primarily involve bone, although this may or may not be that. If there are other nodes, then this may not be a primary bone lymphoma, but those are usually germinal center-like. Nothing on this is particularly raising my eyebrows. The patient does not have a MYC rearrangement or a rearrangement of BCL2 or BCL6. There's small gains, but not large, not numerous gains. And the MYC protein expression is low. So I would not say that this has any striking high-risk features per se, based on FISH with these modest gains, and they probably have a germinal center-like large cell, but again, we don't have the data.
Can you just remind us of what the clinical features of the very rare leg type DLBCL are, and why this would not be considered?
The full name of that disease is primary cutaneous B-cell lymphoma, leg type. It's a mouthful, but cutaneous is part and parcel of that. And so primary cutaneous large cell lymphoma leg type is really involving the skin. It's always non-germinal center-like. And it usually involves the leg, although not always, which is why it's called leg type. Disease involving the bone here is really not that. This is a systemic diffuse large B-cell lymphoma.
Got it. Thank you. So, Dr. Keston, this is a case where the patient had a complete metabolic response by PET, and now is being sent to you to evaluate for whether there would be a benefit of radiotherapy and what type. Can you tell us how you would sort of go about that thought process?
Well, so for diffuse large B-cell lymphoma in general, again, similar, I guess, to Hodgkin's lymphoma, as we discussed earlier, for stage 1 or 2 disease, one would consider adding radiation treatment in circumstances. For stage 3 or 4 disease, clearly the mainstay of treatment is chemotherapy. So the situation with the lymph nodes here becomes pretty important. If it's a stage 1, let's say it's a stage 1AE of the left distal femur. I think maybe that's what this was intended to be. I don't know. Yeah. So if it's a stage 1AE of the left distal femur, I mean, one could give, RCHOP for 6 cycles. We're dealing with a bone lymphoma. Another common regimen for diffuse large B-cell lymphoma in general would be RCHOP for 3 cycles, followed by involved site RT. There's a among the stage 1 to 2 category, there is a distinguishing factor of whether or not it's bulky versus non-bulky, which again has been a bit of a evolving term over the years. Right now, the cutoff, as we said, for Hodgkin's lymphoma is 10 centimeters typically. The cutoff for diffuse large B-cell lymphoma is typically 7.5 centimeters. I think this one was measured at 7.4 centimeters. So it's sort of like, I don't know, almost bulky. Stage 1 AE lymphoma, diffuse large B-cell lymphoma. So if it were isolated to that location, then yeah, I would be very inclined to add involved site RT to this location. It's basically almost bulky. It is in a solitary skeletal site if it's stage 1. That is a site where radiation treatment could be easily delivered without causing much in the way of side effects. And so I would add radiation treatment. The question, so the only real toxicities that one might see with radiation treatment in a situation like this would be knee arthritis, joint synovitis, in joint inflammation, things like that. In general, if one is able to keep the dose of radiation below 45 gray to the joint, usually the outcomes are pretty good. In this situation, we would not be going typically beyond 36 gray. So I would not be super concerned about, knee complications, but I certainly would be doing everything I could to avoid the knee joint. I'm not sure you can in this case. I would probably be trying to give the actual knee joint where the synovial, fluid is, the joint itself. I'd probably be limiting that to a little lower dose than the entire target. And so I personally would use IMRT. I don't think it's necessarily, required in this case. Another big issue with radiation treatment is you want to spare a portion of the circumference of the skin so that you do not cause or you reduce the likelihood of lymphedema. So, for me, that's something that's much more easy to accomplish with IMRT and avoiding the knee. And so I would do that in this situation personally. Intensity modulated radiation therapy in general provides a mechanism of multiple beams within a field, different intensities throughout the radiation therapy field from various angles, and gives us a little more control of the dose distribution.
Great, thank you for that answer. That's really helpful. So I think in a case where there's bulky or near bulky disease involvement in a very assuming again in this case that it's in a very centralized area after a metabolic response with a chemotherapy regimen, it seems like it would be appropriate to add some consolidative radiotherapy, and IMRT might be ideal, but also not a complete requirement.